So for Unit 3, we're going to go over the musculoskeletal system. But first, I thought you guys would like to know about Jojo. So Jojo is my other dog. You can see her sitting next to Oswald there, taking her camping. She has to wear her jacket because she's got shorter fur and she gets very cold, whereas Oswald's a fluff ball. But you can see she's a very good pillow. She loves to cuddle, and so my kids fall asleep on her very often. So we have 2 pages worth of objectives for this. We're going to go over fractures. We're going over assessment when it comes to musculoskeletal injuries. We're going to talk about osteoporosis, osteoarthritis, and amputations, and then some of the complications that come with musculoskeletal injuries. So first, let's talk about fractures. When it comes to fractures, there's a lot of different terminology that you're going to have to know. So you have open versus closed fractures, complete versus incomplete fractures, displaced versus non-displaced, open versus closed reduction, and then external versus internal fixation. So an open versus closed fracture is just to have to deal with the skin. So an open fracture means that the fracture has poked through the skin, or the skin has been damaged in some way and potentially bacteria has gotten to that fracture, as opposed to a closed fracture that still stays within, like our skin stays intact, but the bones are broken inside the skin. And so we really are worried about those open fractures in particular, because when the bacteria gets into the bone, it can cause a lot of complications. And so we're really watching our patients for infection when they have an open fracture versus a closed fracture. A complete versus an incomplete fracture, that just means the fracture goes all the way through the bone if it's a complete fracture. And so a good example of an incomplete fracture would be like a green stick fracture, which is where kids get this frequently and the bone kind of bends and just kind of breaks off a little chunk on one side of the bone, like a little splinter almost. It still stays attached to the bone, but that fracture doesn't go all the way through the bone itself. A displaced versus non-displaced fracture. So a displaced fracture is one that has moved away or has angled away from the other piece. And so the displaced ones are the ones where you're like, oh, something's wrong here, right? Like where the foot's hanging at a weird angle, that sort of thing. Versus a non-displaced, where we'll just most likely have swelling and pain at the site, but it still looks like a straight leg, a straight foot, straight finger, that sort of thing. An open versus closed reduction. So to reduce a fracture means to actually bring it back to where it needs to be. So this would be if it was a displaced fracture, but it's also true for no fractures at all. So like if you dislocate your shoulder. So if the shoulder's dislocated, we haven't broken anything, there isn't a fracture, but still that shoulder has to be reduced or brought back to the spot that it needs to be. And so a closed reduction would be an example of like a dislocated shoulder, and the patient comes into the emergency room or urgent care, and the doctor puts that shoulder back into place. Then the reducing stays within the skin itself. The patient doesn't have to have surgery. It's just the doctor manipulating that arm back into the socket. This can happen with fractures too. So if the leg is angled at a weird angle and we need to reduce it back to straight, that they don't necessarily need surgery. Sometimes the doc's able to just kind of pull that leg back into place with just some mild sedation, and then we splint it really good so that it stays straight. But sometimes the patients do need an open reduction. And so an open reduction is an actual surgical reduction. So they're actually going to cut the patient open and put the bones back into place using plates, screws, rods, whatever material they need to keep those bones together. An external versus internal fixation. These are like the fixation devices that we use to keep those broken pieces together. So I already talked about in an open reduction how they'll use plates, screws, rods, that sort of thing. Those are internal fixation devices. An external fixation device, they're more rare, but you can see them on NCLEX, which is why we go over them. And they're actually hardware that's on the outside of the skin, but it's drilled into the bone itself. So it's not something that you can remove. Like this external fixator has been placed into the bone and is just sitting outside of the skin. And so we worry about infection with those. So we watch the skin very closely. The patient needs to keep those areas clean and dry. Again, external fixation devices are rare, but I have seen them in a few patients. And so when you go to clinical and you're in surgery and you're following like an orthopedic surgeon or somebody who's going to do one of these repairs on a fracture, you might see the term ORIF, which stands for open reduction internal fixation. And so based off of what we just went over, it means the patient's having surgery, so they're cutting the patient open to reduce that fracture, so the open reduction. Internal fixation means that they're going to have to use some sort of hardware to keep those bone pieces together. When it comes to fracture healing, there's a few different steps. So the first is a fracture hematoma. And so there's bleeding at the break. So whenever the bone is broken, there's going to be bleeding, and it does usually create a clot or a hematoma within the first 72 hours after injury. So like within the first 3 days, the bleeding will stop because it'll start to clot. The hematoma then converts to granulation tissue, which usually happens around 3 to 14 days after injury. And so you can see in these images here that hematoma is that image A, and then converting to the fibrous, that granulation tissue. This is the fibrous network for B, and then the osteoblasts start showing up at C. And so minerals that we need for bone, right, calcium, phosphorus, magnesium, are deposited by the end of the second week. And that's figure D. And then ossification of the callus, that's usually takes about 3 weeks to 6 months. And that's once that callus has ossified, that's when the cast can be removed. So again, it really depends on where the break's at and how quickly the patient heals. But the quickest a cast will come off is usually at around 3 weeks, but it can take months depending on the patient. The consolidation aspect is when the distance between these pieces start to shorten. So, we've got this break, we've created the granulation tissue, and then we build in here. And so we've kind of built between that space. And then in E is when the body starts to shrink it back down to the normal size. That can take up to 1 year after the injury. And that's usually when the bone returns to like a pre-injury strength, is at that like 1 year mark. But again, it depends on the patient. If it's a really young, healthy patient, they can heal quicker. But when it does come to bones, we still want to give it time with those injuries. There's a few things that we can do when it comes to fractures, but the biggest thing is we want to immobilize the injury, and we can do this in a few different ways. So there's traction, and there's 2 different kinds of traction. There's skin traction and skeletal traction. There's splinting, which we've kind of touched on, casts, which I'm sure you guys have all been familiar with this, whether you had one as a kid or you've known somebody who's had a cast. And then that fixation, which is what we talked about that when we were talking about terminology. So that surgical repair, whether they're using that internal fixation or the external fixation device. So traction is we're kind of creating a pulling sensation. And so skin skin traction is just like we're just pulling on the patient's skin. So there's a few traction devices we'll use in the ER for some of the big fractures that help just kind of straighten the leg out and hopefully bring the two ends of the damaged bones together so that we can help prevent some of the bleeding. And it also helps with the pain too. So a lot of that pain is from the bones being separate and not together. So when we get them back together and it's not bleeding as much into the skeletal tissue, it's not as painful and they don't get as many spasms, which is also creates the pain. And skeletal traction does something similar. It's just they have to have surgical pins in place for skeletal traction. And so just like with the external fixation device, these pins are surgically implanted into the bone and then they come out of the skin. So we really do need to watch those areas that the device comes out of the skin. So we can still definitely clean the area with soap and water, but we also want to be teaching our patients to watch for signs and symptoms of infection. And then so the skeletal traction with these pins, then those are the pictures where they have weights kind of hanging up on pulleys to create this traction on the bone itself. It does tend to help with pain for these patients again. But I haven't seen skeletal traction since I've become a nurse. It's just something that NCLEX still covers sometimes, and you may see it in some very specialized orthopedic surgery centers. Splints are like the beginning of casts. So splints are short term and they allow for swelling because we know that it takes about 72 hours for that hematoma to form. And so within those first 3 to 5 days, the patient is just getting more and more swollen from the injury itself. And so we don't want to put a cast around them because a cast is hard and it doesn't allow for that swelling to grow. Whereas a splint is like half of a cast, essentially. You just have a piece of fiberglass that's going to keep the bone in the position we want to, and then we ACE wrap around the splint. And then it allows for that swelling. And then a cast is generally placed after swelling has stopped. So at that 3 to 5 day mark or after surgery, depending. There are different methods or different materials that they can use for casts. Fiberglass is the most common. I have seen some 3D printed casts starting to come out, which are really cool. It's a cool technology they've come up with. They're almost web-like, and so the patient's skin is exposed more than if it was like a full fiberglass cast. And the 3D printed ones tend to be waterproof too, which is really nice for the kids who've injured themselves during summer. We can also use plaster for casts. This is more rare, but because it takes a long time for plaster to actually solidify. The big things when it comes to casts, the big education points for our patients is we can't get it wet for the fiberglass and plaster. We can't get it wet because it warps the fiberglass or the plaster. And then we really don't want our patients putting anything in those casts, even if their skin itches down in there. Like, don't put a pen down there to itch. Don't put anything down there because then it gets stuck. And then they start to have skin breakdown between that object and the cast and their skin. And then when it comes to the fixation, like I said, we talked about this before. It's a surgical repair, so they could have those internal plates, rods, or screws, or that external, huge external fixator device. And so we talked about for those skeletal traction pins and then the external fixator device, we really want to watch for signs and symptoms of infection. So what kind of drainage are we looking for? Purulent, okay? It is still something coming out of the skin, so serous drainage is normal, just like when somebody gets a new piercing. Like, it's okay to have a little bit of drainage around the area. They just want to watch for that purulent kind of drainage or foul-smelling drainage. That's what we really want to watch out for. When it comes to musculoskeletal injuries, it is all about assessment. And so we're watching for these things where we really want to keep an eye on these sort of assessment pieces. So the color of the skin, temperature of the skin, cap refill, pulses, especially distal to the injury site, edema or swelling, if the patient can still feel or have sensation, if they can still move things. Again, distal to the injury is important. So yeah, they could have fractured their ankle, but we still want to see if they can wiggle their toes. And then pain is very important when we're assessing these patients. So it depends on what we notice when it comes to if we're assessing this and we notice an abnormality. Let's say the patient's getting worse and all of a sudden the swelling has gotten so much worse. We want to try and decrease that swelling first. And so to do that, we're going to elevate, right? So for a wrist injury, if they've got a cast on their wrist, we really want to get that wrist up above the level of the heart, right? Because if they've been hanging their arms down at their sides, of course they could have swelling at their fingers. So that we really want to elevate first to see if it helps with some of the symptoms that the patient's having. Like if they start to be able to wiggle their fingers again and they start feeling things again. If it still continues to worsen after we've tried improving that swelling, then we need to cut the cast to relieve the pressure. And what's cool about cast cutters, I don't know if any of you guys have seen cast cutters, they look like really sharp circular saws, like little mini sharp circular saws, but they don't actually rotate. Like the saw aspect doesn't rotate, it just vibrates back and forth. So you think you're like cutting the cast with a circular saw, but you're really creating this vibrating effect that helps kind of break apart the cast. So you're not going to cut your patient is the big thing when it comes to cast cutters. All right, we're going to take a little momentary break since it's been about 15 minutes or so, and then we'll head on to complications after this in the next video.